Hello, everyone. I hope everyone's well. I just wanted to apologise quickly about last week. Unfortunately, we had some illnesses, so we weren't able to do last week's session. However, I'm going to be doing that today. So we're going to be surgical emergencies too. So looking into some more surgical emergencies and how to manage them. Okay, so this is just the updated program with the dates. So everything's just going to be pushed back 1 week. So it'll still be on Tuesday at 6:30, but it'll just extend until the 14th of May now. Okay, so straight in with case one. So we've got a 72-year-old female who's admitted to the general surgery ward with vomiting, indigestion, and severe abdominal pain. Past medical history, so she's got ischemic heart disease, type 1 diabetes, osteoporosis, gastritis, and liver cirrhosis. She's also known to have alcohol excess. Drugs include aspirin, amlodipine, clopidogrel, naproxen, lansoprazole, insulin, cholecalciferol, and alendronic acid. So quite a few there. And overnight, she becomes increasingly nauseated and has 2 episodes of dark coffee ground vomit. These are her observations. So respiratory 17, heart rate 117, so a little bit tacky. Blood pressure is 90/78, so it's a little bit low. Temperature 37.4. So the question here is, what do you think the likely cause is here? So I'll put the poll in. Okay, so we've got a few varied answers here, so we'll run through them. So the answer we were looking for was an upper GI bleed. We can run through it. So the presentation she's coming in with, the vomiting, indigestion, abdominal pain, especially in the epigastric region, that all would fit with sort of a pancreatitis picture. I guess the real concerning thing here is that she's had 2 episodes of dark coffee ground vomit. And I can vomit with pancreatitis, but coffee ground vomit is normally what we look for with an upper GI bleed and should be concerning for that. Lower GI bleeds normally present with problems in the stool. So you might be seeing blood in the stool. You might see a drop in hemoglobin. You might see frank blood in the stool. But again, if you're vomiting up some sort of dark coffee ground vomit, then that's more suggestive that we've got a bleed a bit higher up. And when we describe it as coffee ground vomit, it's because it's normally got blood in it. Okay. Okay, so just to recap here on her past medical history. So we've already said she's got ischemic heart disease and diabetes, osteoporosis, gastritis, and liver cirrhosis, and drinks a little bit too much. And her drugs are listed there. And if we're presuming she's having an upper GI bleed, the next question is which agent should have been stopped or when she came into hospital. And now knowing that she's potentially having an upper GI bleed, which drugs also could be contributing to that. Okay, good. So it looks like everyone's on the right lines here. So the answer here is A. So in the case of an upper GI bleed, we need to stop any sort of anticoagulants, antiplatelets, NSAIDs, corticosteroids, anything that will exacerbate the bleeding. So I think things like clopidogrel, aspirin are sort of ones that are quite common and easy to remember, but just remember about NSAIDs and corticosteroids as well. So I've just made a chart here which highlights the main drug classes which increase your risk of bleeding and which ones you should consider withholding during an acute upper GI bleed. So other drugs that we haven't yet mentioned are aldosterone antagonists, SSRIs and bisphosphonates. So the table on the right-hand side shows the risk of upper GI bleeding, and interesting, she actually shows the combined risks. So our patient was on an NSAID, an anticoagulant, and low-dose aspirin, so her risk is 6.9 times more than someone who's not on those drugs. So that just highlights quite how much polypharmacy can actually affect this. So especially in hospital, you've got to be on the lookout for this. Okay, so going back to our patient, so she's now hypotensive, she's tachycardic, and she has had further episodes of hematemesis. So you now suspect this is an upper GI bleed, and you pull the emergency buzzer to get help, and you use the ABCD approach, which is how you should always look at these emergency situations. So starting from A, she's maintaining her own airway, it's patent. B, we're looking at her respirate, that's okay. O2 sats are all right, equal air entry bilaterally. Moving on to C, so her blood pressure there is low, which is a late sign that she's probably having a GI bleed or a bleed from somewhere, so that's not good. She's tachycardic, again, a sign that she's bleeding probably. Pulse is regular, cap refill time's long, and she's cool peripherally. So this is showing this is sort of a late stage of the GI bleed. Heart sounds are normal. Always check the blood glucose, and D, GCS as well. So 15 out of 15 at the moment. She's not unconscious or anything. And her pupils are nice, reactive. Abdomen's tender in the epigastric region. And there's the presence of melena. So at this point, they've then found that she's also got blood in her stool, that sort of sticky, tarry melena, which is classical as well, but no fresh blood, and she's got soft calves. So things that we want to be thinking about, you're going to take some blood, so you want a full blood count, you want Usanese, a coag, LFTs, VBG, and a group in save. You get some IV access, and you give her a stat bolus of 500 mils of Plasma-Lyte or Hartmann's, depending on whatever you have in your hospital. And the question here is, what other medications would you prescribe? So this one's a bit trickier, but we'll walk through it. Oh, looks like I already gave you the answer. Okay, so I think a few people maybe saw that there already. Sorry about that. So the answer here is D. So there's a few bits we want to be giving. So terlipressin causes vasoconstriction, and that reduces the blood pressure in the portal system. So we want to use it for anyone with a suspected variceal bleed. So we want to try and think with an upper GI bleed, what is the main cause of it. And with variceal bleeds, guidelines also suggest prophylactic antibiotics. So we give comoxiclav or ciprofloxacin if they are penicillin allergic, which she's not. There is a little bit of variation on recommendations for PPIs. As a general rule, if you suspect someone's got a non-variceal bleed, then you don't give them the IV PPI. But some places recommend PPIs before 24 hours, and some places recommend it if you suspect a variceal bleed. So it's important just to have a rough idea of what your diagnosis is and to make sure to follow your local policy, as always. So if you just talk through how to recognize and manage an upper GI bleed, as we've mentioned before, we always use an A to E approach. Beware they may be actively vomiting, so it's safest to use nasal cannulae. And we need to get some IV access and take some blood so we can assess the situation. And remember, at E, we need to expose the patient and perform a PI. So we're looking for signs of melena or fresh blood. And when taking bloods, it's also good to be aware of what you're looking for. So this is one of the things they like asking in OSCEs. Why are you taking these specific bloods? So The full blood count will give us a hemoglobin, so that'll help tell us if it's dropped, if this is a big GI bleed, if it is a GI bleed, and if you're going to need to consider actually transfusing them. It'll also show up their platelets, so if they've got any problems with clotting, and if we need to replace those. You'll use an ease, so that provides us with a urea, which is increased in upper GI bleed. And this is because the blood is actually digested into a protein, which is then metabolized into urea. So if you've got a sky high urea, then that also is suggestive of an upper GI bleed, obviously, if in the right context. You want a coagulation for the INR just to make sure it's normal, it's not super high, because if it's high, we'd have to treat that and correct it. LFTs to see if there's any liver dysfunction. And coag's actually useful for that as well, because the coagulation is affected in severe liver disease. And of course, we want a group and save and a cross match ready for any blood transfusion. And just a reminder of the causes on the right hand side, just to have in the back of your head: peptic ulcers, duodenal ulcers, very common. Mallory-Weiss tears, so if they've been vomiting a lot, you can get bleeds from that. Esophageal varices, so you want to be suspecting this if you've got any sort of deranged LFTs, history of drinking or severe liver disease, and esophagitis is another one. There are a few other ones as well, but just to have a few of the main ones in the back of your mind is always useful. And the symptoms here, so obvious ones are hematemesis, which is commonly described as coffee ground vomit. So you'll definitely be asked in F1, F2 to go and look on a ward at a patient's vomit to see if it is actually coffee ground. And melena, which is tarry black stool. And if it's a severe upper GI bleed, then they'll start to show signs of shock, because they're hypovolemic, so they'll be hypotensive and tachycardic. And at the later stages, they also get reduced urine output. So just want to be aware of those things as well, to keep on top of everything. All right, and then this is just the nice guidelines for initial management of an upper GI bleed. So the main thing being reversal of your anticoagulants and blood products. So obviously it's important to have your bloods taken early, so that you can have a look at the clotting and the INR and the full blood count and everything to inform this. And in addition to this, we also advise fluid resuscitation initially and senior help. So in the time it takes to get some of the blood or the other blood products, and we always advise giving some fluids. Again, if they've got severe heart failure, then you might give them a smaller bolus, but generally we like to give 500 mils of something like Plasma-Lite or Hartmann's. And there will be individual pathways in your own hospital, so make sure you familiarise yourself with the local trust guidelines. And this is just a quick slide on the PPIs. So not routinely offered before endoscopies as an initial treatment. And as I said, it depends on if you suspect it to be a varicose bleed or not. So it's not the end of the world if you're not sure, but if you think it might be an esophageal varice that's bleeding, then you would want to be giving them telepressin. And the same here with the proton pump inhibitors. So that shows the BNF down there for if you've got a bleeding severe peptic ulcer. So you can give something like pantoprazole IV. Okay, and this just shows you what a guideline might look like. This is one from the Highlands, but they have similar ones all over the UK. So in this management, the split is dependent on if they're hemodynamically stable or not, which is quite a common way to manage it. So resuscitation is the first thing we want to be doing if they're unstable, doing all the things we've discussed, so fluids, taking bloods, monitoring, getting some senior help, seeing if you need to reverse anything, any anticoagulation, and then there's sort of a bundle that you can add in for varicose bleeding. Again, both things we've discussed, that terlipressin and the coamoxiclav. And then the focus is mainly on getting the endoscopy, which is the definitive treatment. Okay, so back to our patient. We think she's having an upper GI bleed. She's hemodynamically unstable. And so she's going to have an endoscopy immediately after resuscitation. There are two scores that need to be calculated around endoscopy, and these are the Glasgow-Blatchford score and the Rockwell score. So the question here is, what is the purpose of the Glasgow-Blatchford score? Anyone got any ideas about this score at all? Okay, so we've got a bit of a spread here on some of the answers. So the answer here is A, so identifying low-risk patients that don't require inpatient intervention. So they might still get an outpatient endoscopy, but they're not going to apply blood products and endoscopies straight away. So this is important because when we risk stratify patients, obviously there's only a certain number of spaces for endoscopies, and we need to prioritize the people who it's life-threatening. So those hemodynamically unstable patients who are requiring lots of blood products and reversal of their anticoagulants and things like that, those will be the people who are high risk, who will need to have an urgent endoscopy whilst they're an inpatient, and blood and all those kind of things. And this is what stratifies people who sort of a little bit less urgently, who might be just bleeding a little bit. Obviously, it's still classified as an upper GI bleed. It's still concerning, but they're low-risk patients. So here we've got both scores up. So the Glasgow-Batchford score uses hemoglobin, systolic BP, heart rate, the presence of melena and syncope, and then past medical history, so hepatic disease and cardiac failure. So it would only be low risk if they scored 0. So it obviously needs to be hemodynamically stable, which is what we mentioned. So that's not like our patient. So our patient here would score more than 0 on a Glasgow-Batchford score. And then looking over to the right for the Rockall score, this gives you information on the severity with the risk of rebleeding and mortality. So they use a few different markers. So we've got age, comorbidities, presence of shock, source of bleeding, and any major stigmata of recent hemorrhage. So this is more looking at actually their morbidity risk afterwards. And scores less than 3 are a good prognosis, and more than 8 are poor prognosis. So if they're older with lots of comorbidities, they're in shock, and they've got recent bleeding, stigmata of bleeding, then obviously that worsens your outcomes. Are there any questions at this point? Okay, we'll move on then. This is just to recap the NICE guidelines. So this suggests that you should do both scores. So if you're working on a ward with endoscopies or in general surgery, it's a useful thing to just know where to find what the score is, because the surgeons and the GI consultants will want to know what the scores are. So they suggest early discharges for patients with a Glasgow-Batchford score of 0. And on the right-hand side, it gives us information on the timing of endoscopy. So the more unstable, the sooner they need the endoscopy, which makes sense. But the aim is to get an endoscopy within 24 hours for anyone who clinically needs it. Right, that's that. Okay, so moving on, we've now got case 2. We've got a 54-year-old female who's admitted following a horse riding accident where she sustains an open book fracture of her pelvis. So she has a pelvic binder on and she undergoes ORIF. She's in the hospital. And one day post-operatively, she becomes breathless after this surgery. So you go and have a look at her, and these are her observations. So she's tachypneic at 24. Her O2 sats in 90%, so this is a bit low, especially for a 54-year-old lady who was previously healthy. Heart rate of 120, so she's tachycardic. Blood pressure 104/82 on the low side. And she's aporexial. ECG is performed and it shows S1Q3T3 change. Now, what is the most likely cause of this? Okay, so we're getting a few answers in. And whilst we're on this, can anyone tell me what the S1Q3T3 change means and which presentation it's linked to? So that will be quite helpful with getting this answer correct. If you know, feel free to pop it in the chat. Okay, so we've got a little bit of a spread here, but most people have got the answer correct. So the answer here is a pulmonary embolism. So the S1Q3T3 change in an ECG is also known as the McGinn-White sign, and it's associated with right heart strain secondary to a pulmonary embolism. So you won't get it with every pulmonary embolism, but if you get a really big pulmonary embolism that causes right heart strain, you will see this. And what you see is you see an S wave in lead 1, you see a Q wave in lead 3, and a T wave in lead 3, inverted T wave in lead 3. So if you haven't heard of it before, that comes up a lot in exams. And yeah, so large S wave in S1 in lead 1, Q wave and inverted T wave in lead 3. So that's how you remember it. And only about 10% of people with PEs actually present with this change, because the most common ECG finding with a PE is actually sinus tachycardia. So that's more common. Okay, fine. So we've obviously got someone with reduced oxygen saturation, sudden onset shortness of breath, tachycardia, and a characteristic ECG. So she's probably got a pulmonary embolism. She's recently had surgery, so that's also could happen. And we've talked through the S1Q3T3, and that shows evidence of right heart strain. So we suspect she's got a PE. What is the most likely cause of her PE, given that she's just had a recent surgery? Okay, so a bit split here between fat embolus and DVT, which is what I expected. So the answer here is fat embolism. So the reason why it's a fat embolus is because she's had a large pelvic fracture, and surgery which predisposes you to a fat embolus. So big hip fractures and big bone fractures, so tibia fractures, femur fractures, things like that can lead to fat embolus. And that can cause a PE. DVT is the other sort of more plausible option here, but we've got no mention of any swelling in her leg. So it's difficult to know. I guess there wasn't anything saying she didn't have anything in her leg, but the more common thing here would be a fat embolus. DVT, if there was any mention, obviously, of swelling in her leg, then that would be the most common. Septic emboli is unlikely because she's not septic at the moment, so she's not got a temperature, and coagulopathy and dehydration are unlikely here. Okay, so we think she's got a fat embolus, which has then resulted in a PE because of the nature of her injury. So yeah, large pelvic fracture. So you order a CTPA, and it shows she's got a PE. So how would you manage her PE? All right, so we've got a bit of a split again here. So the answer here is B. So she's going to need some oxygen because she's got low SATs, and we need some anticoagulation. So it does vary from place to place what you anticoagulate them with, but low molecular weight heparin is never a bad shout. It's in the BNF. So in Scotland, for sure, we use dalteparin, and we use treatment dose dalteparin if it's a confirmed PE, and we use prophylactic dalteparin for patients who are, in hospital with surgery with a risk of getting a clot. In some places, there is variation. So some places, for the treatment of PE, you might favour something like apixaban, but that's obviously not an option here. So heparin infusion wouldn't be correct. The other option people put was aspirin, clopidogrel, and O2 therapy. So obviously the option there is correct. Aspirin 75 milligrams and clopidogrel 75 milligrams. The only place that's really used is in secondary prevention in patients who have had myocardial infarction. So STEMIs, obviously they'll get loading doses, which are higher initially, and then they'll be put on aspirin 75 milligrams, clopidogrel 75 milligrams once daily. So that might be where some people are getting a little bit confused with. But for a PE, we just need to anticoagulate them because they've got a clot. So that does vary a little bit, but in this scenario, the only option that could be correct is the treatment dose dalteparin. Okay, and this just shows again on the BNF. So if you look up dalteparin, it comes up here. You can see it says treatment of DVT, treatment of PE, and it does it by body weight. So you give them those units once a day, and normally prescribe it for 3 months to 6 months, and they normally get reviewed in a PE or a DVT clinic. And again, always follow your own trust guidelines. As I said, some places prefer to use DOACs. Okay, so moving on to our next case, we've got a 29-year-old gentleman who's admitted to the orthopedic ward following a road traffic accident. So he's sustained a right proximal tibial fracture and has multiple broken ribs. He's awaiting an ORIF tomorrow and is placed in a cast and prescribed analgesia. What medications would you want to prescribe him initially? So he's come into hospital, he's got quite a few breaks. What things would we like to put him on whilst he's an inpatient in the orthopedic ward? So these kind of questions are useful for anyone who's going to be working on an orthopedic ward. You'll get lots of patients who come in with sort of similar presentations, and they'll all need a baseline set of medications whilst they're on the ward, in addition to their regular meds. Okay, so you've got a few answers here. So I think people have avoided A, B, and C, which is correct. So we'll go to the answer here. So the answer here is D. So you can work through this in a few different ways. In orthopedics, there's a few things. Obviously, he's got broken bones, he's in pain, so we're going to need to give him some analgesia. We like to give baseline medication, something like a paracetamol 4 times a day, to sort of give a little bit of analgesia at baseline, and then something stronger. Quite a lot of orthopedic wards preference oxycodone over morphine, but it could be morphine as well. If you're giving an opioid, you always need to give 2 other things, which is some kind of antiemetic and some kind of laxative, because you can otherwise end up with people vomiting. They then get electrolyte disturbances, or equally you can get constipated. That can put you into retention. So we always need to think about analgesia, a baseline one, a bit of a stronger one, and then we've got an antiemetic there, so the cyclizine and macrogol and senna. Quite frequently they are prescribed more than one laxative. You don't want to be giving them tons of different laxatives, but giving them 1 or 2 they're both different types of laxatives. So that's not the end of the world. And they're normally PRN, so they can have them as they need, depending on how constipated people feel. And then we've said he's waiting an ORIF tomorrow, so he's probably going to be fasted. So IV fluids, again, we want to keep people hydrated. Slow fasting fluids are not a bad idea, especially in someone who's 29 years old, and we're not going to overload him. So the other answers here that are incorrect. A, there's no suggestion here that he needs a blood transfusion. B, we're missing any kind of analgesia. C, we're missing analgesia. He doesn't need oxygen therapy. He's not got cyclazine. He's not got any kind of laxatives. And then E, we've got a little bit here. So we've got the morphine, we've got the ondansetron, but we're missing the baseline regular analgesia like paracetamol. And we haven't got any fasting fluids or any laxatives. So just try and think about all of the needs of the patient when you have to prescribe the baseline meds. Okay, so that evening you're asked to review him because he's still got some pain. So on examination, he's slightly tachypneic, tachycardic, blood pressure stable, alert, aporexial. And the right foot has reduced sensation on the dorsum and is very swollen and tender. So the question is, how would you... So you've got someone with a large tibial fracture. Who's now in increased pain. How are we going to manage them? Okay, so most of the answers here, well done everybody. Looks like we've got the correct ones. So the answer here is B, we want to call a senior for a review of the compartment. So contact the pain team for a review. Obviously, in another scenario where it's just the pain and there's no concerns for compartment syndrome, that might be correct. Switching oxy to morphine, again, we've discussed in previous scenarios, in other sessions, how moving from one opiate to the other can sometimes help with the pain, and increasing the dose of oxy. But again, the important thing here to recognize is that it's actually not just a pain review. He's got changes to his foot, which are in keeping with compartment syndrome. So that is a medical emergency or surgical emergency even. Yeah, so here are some of the symptoms to look out for. So it's sometimes referred to as the 5 Ps. Sometimes it's 7 Ps, but I think 5 are the main Ps. The main one that people remember is disproportionate pain. So if someone was okay before, and they're on some analgesia, and then they've got pain that's completely disproportional, no one can touch the leg, no one can touch the foot, they can't move an inch, then you've got to be a bit more concerned, okay? And also this is another reason why if you get sort of overnight, if you're on call and you get asked to come and do a pain review for patients, it can be easy to think you'll just increase their pain meds. But it's also really important to actually go and assess the patient, because if you didn't go and see the patient and you just increase their pain medication, you'd be missing something like this. The next P is pallor, so it normally is much paler than the other side, and they also sometimes describe paresthesia, so you might get numbness in the foot or the leg, depending on where the compartment is. So, and you'd want to try and feel the pulse. Sometimes it's so painful you can't actually even try and feel for a pulse, but it might be faint. and then paralysis. So you might not be able to move that leg either. So the important thing with this is if you suspect it at all, just to get someone else to come and have a look at it. You're not expected to be able to be sure of yourself or treat it or anything like that, but you need to just be aware of the symptoms and aware of the risk factors as well. So anyone with a big crush injury or a large bone fracture, and restrictive cast can do it as well. So in this case, they had a large bone fracture and they were put in a cast as well. So those two things are risk factors for that. And you can get a compartment syndrome in any of the compartments in your leg. Essentially, you get a swelling of the muscles, and that leads to compressions of the nerves and the blood vessels, which is why you get the pallor, because you're compressing the blood vessels, why you get the paresthesia and the numbness and the pain, because you're compressing the nerves. Okay, so we get a senior review, and they come and see the patient because you're concerned about this compartment syndrome because of those 5 Ps. Does anyone know what the definitive treatment for compartment syndrome is? All right, so we've got a few things going on here. We've got the fact that she's hallucinating and the fact that her pain is not well controlled. So we need to do 2 things really in our decision. We need to stop her hallucinating and improve her analgesia, increase her analgesia, or change it to improve her pain. Any other answers? Okay, so the answer here is switch the morphine to oxycodone. So more people went for B. So increase the morphine sulfate to 10 milligrams QDS. Now that probably would help with the pain. If she wasn't hallucinating, that would be a good thing to do. We've started at a low level. It's okay to increase the morphine, especially if she feels that when she takes the morphine, she gets a bit of relief from it. But at the moment, she's also hallucinating. So if we increase the dose of morphine, that's probably going to make her hallucinations worse. And if she's hallucinating, she might fall. You can get scared from that, but it's not great to have someone hallucinating. They're not going to eat and drink properly. They're not going to be able to do their rehab properly, and it's unsafe. So the most common cause of hallucinations, especially in surgical patients, is morphine. So oxycodone less commonly has that kind of side effect. Cyclizine can also cause hallucinations, but it's far less common. So I would be inclined at first to switch the morphine. Okay, so she's been switched to oxycodone and you re-review her 2 hours later and she's no longer complaining of pain. So that's good. So again, if you ever change something with a patient with a pain medication, it may seem easy just to put the pain medication up or switch the pain medication and then leave them. But it's always good practice once you've changed a medication or increased medication or decreased medication to go and see how the patient's doing with that. So her obs are here. So her respirate is 7. So that's low. Oxygen, that's 94%, a little bit lower than we'd like, probably because she's not breathing properly. Heart rate 78, which is fine. Blood pressure 110, probably. It's probably all right. She's just, it's late in the day. She's lying down. Aporexial, so she's not septic. GCS 13 out of 15. Pupils are equal active to light, but they are pinpoint pupils. So the question here is, what is the likely cause of her reduced GCS? Okay, so people seem to have got this one. Well done. The answer is E, opiate toxicity. So this is a pretty classical history of an opiate toxicity. We've got a patient who's likely opioid naive, they're normally a bit older, and has been given some doses of opioids. So she's got a reduced GCS, she's got respiratory depression, and she's got pinpoint pupils. She is opioid toxic. So again, when you're dishing out morphine or oxycodone or any of these medications, it's easy to sort of think that everyone can just have them. And again, these were actually quite low doses that the patient's getting. Some people are opioid naive, and especially if you're smaller and your kidneys don't work particularly well, but it can just happen to anyone. You really can become opiate toxic quite quickly. And if that happens overnight, again, that's an emergency, and it's not a situation that you want to overlook. So it's really important when you're giving out these medications just to go and check, have a look at the respirates, have a look and make sure you haven't overdone it. So, yeah, we've discussed she's got reduced respiratory effort, she's got reduced consciousness, and she's got pinpoint pupils. So you're concerned she's opiate toxic. How would you manage this emergency acutely? So again, this might be your job if you're the F1, if you're on overnight. You might be called by the nurses to say, oh, we think this patient's opiate toxic. Can you come have a look at them? And you would need to have a look at that scenario and try and manage the patient. Okay, great. So everyone knows how to manage this. Naloxone. So if you come across a patient who has symptoms of opioid toxicity, Some patients, if they're a little bit drowsy, sort of heading towards opiate toxicity, you can just either stop their opiates or reduce their opiates by a lot. If they're, in this case, like this patient who's actually, she's got reduced respiratory effort, she's, got reduced consciousness, she's at risk here. We need to reverse it with the naloxone, okay? This is just a slide to highlight the signs of opiate toxicity. So we often think of these symptoms in A&E with overdoses, but you need to be aware of atogenic opioid toxicity, which is actually far more common than you think. So we're giving out all these opioids in surgery. You need to be aware that you can actually be overdosing them. And BNF here on the right, so that just shows naloxone up here and its indication for acute opioid overdose. We've got at the top here your management, so we give naloxone and we suspend all the opioids. Okay, so moving on. Case 5. So we've got a 71-year-old gentleman who's admitted with necrotizing fasciitis. He undergoes an extensive emergency surgical debridement, and you complete a post-op review. All right, so we've got his bloods here. Hemoglobin's looking normal, which is good. White cells very high, but he has got necrotizing fasciitis, so that's sort of expected. Again, the CRP is very high. He's just had a surgery and he's got necrotizing fasciitis, so we'd probably wait for that to go down a little bit. Urea is also high. Creatinine is very high. Sodium is a little bit on the low side, and the potassium is 6.6, so he's hyperkalemic. So there's a lot of things going on here, but we sort of are expecting his white cells and his CRP to be high, but his urea and his creatinine are high, which would suggest his kidney function isn't great, and he's got a potassium of 6.6, which is dangerous. So what is the investigation required to determine treatment in this case? So that sounds like a bit of a silly question, but there's a specific investigation that you need to do if you saw these bloods to determine what sort of treatment we want to be giving this patient. And as I've said, we already know that he's got an infection, so we're not trying to treat that at this point. So looking at the other blood results, what sort of things would be wanting to check? Okay, so very good. So the answer is B here. So just running down through them. Urine dip probably isn't going to add much to clinically change any management unless we sort of suspected he's got a UTI. ECG is the correct answer because we need to determine the treatment for his hyperkalemia. So at 6.6, his potassium is the thing that we're really worried about. Obviously, he also does have an AKI with a high creatinine there. But the most urgent thing that we need to be treating is the potassium because, that could put him into he could have an arrhythmia, he could arrest. Blood pressure, again, might give you a bit of an idea about his AKI, but he's just had undergone severe surgery, so I don't think a BP would be the first thing to do. Chest X-ray is not really relevant here, and magnesium level that was mainly put in because it is useful if the patient has hypokalemia. So lots of patients will have hypokalemia, and if you try and treat them with potassium, it doesn't work if they have a low magnesium. So that's useful if you've got a patient who's got hypokalemia. It's always good to do a magnesium level to check if their magnesium's low, and if that's low, you need to replace the magnesium. However, in this particular scenario, we've got a high potassium, which is dangerously high, so we need an ECG to have a look and see if it's actually affected the heart. Does that all make sense? Okay, so we get an ECG and it shows elevated T waves. As I've said before, we've got a severe AKI and hyperkalemia. and quite frequently those can go hand in hand. So at this point, he feels he's got shortness of breath, palpitations, and some nausea. What is your immediate management now that we've seen these tool-tented T waves on the ECG? Okay, so this is the last question. If anyone has any thoughts about what the answer is here. Okay. Very good. So a lot of the answers here could have been correct, but the answer that is completely correct is A. So this was a difficult question because obviously he has got an AKI. We'd want to treat that with some fluids. The IV plasma light's not wrong, but at this moment in time, we've got a patient who has hyperkalemia and has ECG changes because of the hyperkalemia. So that's our priority. That's what we need to manage first. Then we'd manage his AKI. Okay. So that rules out E because we're not actually treating the hyperkalemia. D is also a good answer. So IV dextrose with insulin and salbutamol nebs. So we've got some parts here, but we're missing the calcium gluconate, which is what we use to stabilize the heart when we get an ECG change. So that's incorrect. And then C and B are missing a lot of the other meds needed to treat hyperkalemia, but they can actually be used as adjuncts themselves. So if you get a hyperkalemia guideline, you'll see these two sort of down the bottom, but they're not the first line things to go to. So A is correct. If we have ECG changes, we need to give IV calcium gluconate. So it stabilizes the heart by decreasing the membrane depolarization. So we want to make sure that the heart is nice and stable. We're not going to have any arrhythmias. We don't want the patient going into any kind of arrhythmia or arresting. So that's the main thing that we give. And we only give that if the patient has changes on the ECG. And then the other things we need to be doing is we need to try and shift that potassium back into the cells. So we do that with the insulin dextrose infusion and salbutamol nebulizers. So if anyone has any idea about how the salbutamol or the insulin glucose infusions, how they shift the potassium at all, feel free to write in the group chat. If not, I can explain it. So the salbutamol works. It's a beta agonist and it shifts the potassium across the membrane because of its effect on the sodium potassium ATP pump. So it's one of these sort of lucky finds essentially with the insulin glucose infusion and salbutamol nebs. They just happen to shift potassium in the right way. They're not specifically designed to treat hyperkalemia, but the IV calcium gluconate is what stabilizes the heart, and then the other two treatments are how we shift the potassium quickly into the cells to reduce the serum potassium. Okay. So as always, we want to get an ECG if you're concerned in hyperkalemia. Anyone with a raised potassium, there are lots of reasons for having a high potassium. You know, sometimes it can be because the sample's been left around to coagulate, but the most important thing is to get an ECG just to be sure. And I have mentioned, so the guidelines do vary as with everything across the board. So make sure you know what the guidelines are. Always have a look on your intranet, but generally speaking, they're in agreement that any potassium more than 6 warrants an ECG. So up to 6, we sort of look to see, just keep checking it and monitoring the patient. And then if it's above 6, then we want to get an ECG. And these are the changes that we want to be looking at. So you probably all heard of peaked T waves, tall tented T waves. That's the sort of first change you can get. But then once it progresses, everything sort of stretches out. So we get a widened PR interval, we get a wide QRS and that PT. And then we get complete loss of the P wave and we get a sine wave. So if you see a sine wave, pull the emergency buzzer. It's a medical emergency. That patient is very, very unstable then. Okay. Now, this is a bit small for you to see, I appreciate, but I just wanted to get up a guideline again to show you what a protocol might look like. So, as always, look at your own policy, but in this case, they stratified it into mild, so mild, moderate, and severe. So mild is less than 5.9, moderate is up to 6.4, and severe is more than 6.5. And anyone with a potassium of 6 gets an ECG, which is what we discussed. And if there are ECG changes, they recommend IV calcium gluconate. So you administer IV calcium gluconate over 10 minutes, and then you recheck the ECG because we want to see that calcium gluconate is stabilizing the heart. If they're moderate or severe, we then go on to try and move the potassium, as we've discussed, with the insulin dextrose and the salbutamol nebs. So a useful point here is just to be aware that obviously if you are giving insulin dextrose infusions, we want to be checking the blood glucose before we give it, and be mindful of that. If you've got a diabetic, if you've got someone who's sort of got unstable blood glucose, then it's just important to be aware that we are giving that patient insulin glucose infusion. And then you can see down the bottom here, we've got consider calcium resonium and sodium zirconium. So some guidelines suggest it, some don't. It completely depends on where you're at. And as an FY1 or a junior, you wouldn't be expected to start any of those kind of medications. Just want to focus on getting that ECG, raising your concerns to a senior, and starting the initial treatment. Okay. And these are all my references. So if anyone wants to look at any of those before, that'd be great. I can see in the chat, just having a look through. If there are any questions, please let us know now. We will be uploading the slides later, so people can have a look at those and look at the references as well. Okay, and I'll just send the feedback form in there. Thank you all for coming. As always, really appreciate you coming along, and we hope it's useful. We've got a few more, which are getting a little bit more specific in the next coming weeks. So we've got a few sessions which really go into helpful scenarios if you were to be taking on jobs as an F1 in specific specialties, things like ENT and general surgery, orthopedics and pediatrics, just to give you a bit of a heads up on the normal sort of goings and the things that turn up in those presentations. But thank you very much.